Suzanne today is going to cover, we're going to start with the 10-year plan that the NHS has just launched, and Suzanne is very much across that, so she's going to get into that and a bit of detail at a high level within that 10-year plan. And then we're going to start talking around certain initiatives, really around that kind of virtual wards piece, and moving analog to digital as well. So yeah, really interesting session coming up. Really looking forward to hearing this. I'll pass you across to Suzanne now. Suzanne, if you don't mind just giving a brief introduction. I don't think Simfree, I think it's her first session here, so just giving a bit of a background and then we'll jump into it.
Brilliant. Well, look, it's great to be with you once again, and Simfree, particularly to meet you, having met Kerry and Jimmy previously. Just by way of background, as Craig says, I'm 30 years in the NHS, in the English NHS, by background, both as a finance director, CFO, and then latterly 7 years as a chief executive, and now I work independently in the UK, providing coaching but also advisory services to people who are still working incredibly hard in the NHS. And it's a really fascinating place to be, because it means that I get to still work with wonderful people like yourself, only in the English system, who are trying to make sense of what is a hugely challenging environment for healthcare, but also to not only deal with today's challenges, but also to think about how can they make a real impact and difference for the future. And I'm very much enjoying doing that. So hoping to pass on some of that experience and help you have some conversations that facilitate some of the development of your thinking, in order for you to also similarly have that impact back in your own organisations. So look, for those of you who were present last time, I gave you the carrot dangle of the fact that the English system was expecting this 10-year plan to be published. And I was giving you some updates on some quite substantial changes that we're seeing at the moment in the English system. And since we've last met, the government have indeed published the long-awaited 10-year plan. But I also wanted to pick up, I know when Craig and I met to plan for this session, he also gave me some feedback on some of the topics that you've been talking about that would help you in terms of the work that you're doing. And in particular, I think amongst the points that you raised, you were talking about, understanding if sector perspectives are isolated to the NHS, or if sector learning can be shared, topics around technology, and specifically standardised processes that could help to save costs, and also learnings from hospital at home. So thank you so much for providing that feedback and that input, because that's really sort of shaped our plan for today's session, and indeed the next one too. So our plan over the next two sessions is to explore these particular topics further. I'm going to weave in the 10-year plan to it. So we're going to start today with learnings from the plan, and also what the read across is to the Australian health system, but also to bring in some points about the learning around hospital home or virtual wards, how they've worked and the lessons learned. And then in the next session, if I can sort of trail that one, we're proposing to concentrate more on technologies, and in particular, because there's a lot talked about, I think, nationally, internationally, about the big system changes that people are making around technology. But what I'd really like to focus on is, well, so what can you do better with all of the stuff you've already got? So I'm assuming that most of you might already have Microsoft and using Microsoft. So we're going to use what you can do with your existing systems and packages to look at particularly back office functions such as HR and finance. And so when we get to the talking part of our session today, it'd be really good to have some feedback about whether that's going to be a useful shaping or form for our next session. Simfree, just particularly for you, but maybe just to remind the rest of us as well, we set this group up really with some objectives to understand the challenges that are being faced by healthcare globally, in more depth, and to have this as a safe space to explore concerns and challenges, and an opportunity to learn from good practice. And I'm hoping that I'm able to feed that in from the English perspective, but clearly you guys will also have good practice that you've got within your own organisations. And so we purposely leave that time at the end, not only for us to pick up and ask questions about maybe some of the things that I've said, but also to share good examples between ourselves in terms of what's happening well for you, develop new ideas, new solutions. And then lastly, I guess the objective was around just spending some time reflecting on our personal contributions, our leadership and our development. Because when things are particularly challenging, as I know they are, on both sides of the world, then that almost is the stuff that might get sort of lost along the way somewhere. So that's the objectives of the group. And without further ado, let me move on to talking about the sort of 10-year plan. So on the 3rd of July, it was a momentous day, clearly, of this year. The government published its 10-year plan, health plan for England, which sets out the ambitions for the NHS over the next 10 years. It's 168 pages long, so if you're suffering from insomnia at any point, that might be a good read for you to dip into. But within that 168 pages, it includes a really significant number of different policy proposals, including everything almost from, like the golden handcuff for newly qualified dentists, to a shift in the overall pattern of health expenditure, of health spending. It's a 10-year plan for health that aims to set out how the government intends to transform the NHS and to create a health service that's fit for the future. And therefore, it's really acting as our strategic framework for improving healthcare delivery over the next decade. Practically, it's an interesting document. I mean, I think if you stand back and look at it realistically, there's probably nothing significantly new in there for the NHS. It feels very familiar, probably because it builds on the commitments that the government's had and discussions that have been had over almost like the last 25 years. So the reform plans, if you look what the NHS has been saying, that's really all been brought together within this 10-year plan. But I think what it does do, although it doesn't bring anything like radically new, what it does do is I think it gives some real focus of attention for the key things that we as healthcare providers should be striving for in amongst all of the turbulence of delivery in an increasingly challenging environment. So it's helping us to see, I think, the things that we should be paying attention to. Of course, from what I've told you before, the 10-year plan's got a lot riding on it. The government has been saying for the past year, since they came into their term, that the NHS is broken, and they backed that with an investigation in 2024 by an eminent surgeon and governance advisor, Lord Darzi. And that investigation comprehensively highlighted a wide range of problems and the fact that the public satisfaction with the NHS was at an all-time low. So the plan really leans into that rhetoric, stating that the choices for the NHS, it says that the choice for the NHS is stark. It either reforms or it dies. So, some really impactful stuff that they're really setting out their stall with here. And if you accept the government's diagnosis that the NHS is broken, and I think many of us would, then this new plan needs to provide the public and those working in the health system with the hope that it can be fixed by setting out a strong and positive vision, as well as a credible roadmap for how that could happen. So fundamentally, and people are really characterising the plan by this, the plan centres on 3 shifts or changes that the government wants to see. It talks about moving care from hospitals to the local communities. So we see a shift from hospital to community. It talks about preventing illness, not just treating it. So a shift from treatment to prevention. And it talks about realising the potential of digital technology So it talks about a shift from analog to digital. So when I'm hearing people talk about the plan in England, they're talking about hospitals, communities, treatment to prevention, analog to digital. That's the sort of shorthand for how people are characterising the plan. But in addition to that, the plan majors on patient experience, and some parts around equity and inclusion, and what that can bring to play. And behind it all is still this real big challenge in terms of access and waiting times, which is one of the big government's commitments for this term. So what comes through, I think, strongly is a clear understanding of the frustrations that people have with accessing and interacting with the existing health system, and therefore what needs to change. There's no doubt that the plan focuses on issues that patients are saying matter to them. So it addresses head on the issues that have really driven the reduction in public satisfaction to historically low levels over the past few years. So the lack of access to service, poorly coordinated care, poor admin, that means appointment letters sort of arriving after the appointment's even meant to have happened. And of course, behind all of this, as we've talked about previously, the fears of staff burnout have led to many people, both staff and public, asking the most fundamental question of the NHS, which is, will it be there for me when I really need it? So much is made in the plan of putting choice and control back in the hands of patients. And that echoes themes from previous NHS plans. And if the ambitions of the 10-year plan for health are realised, then by 2035, people will have access to better information, will find it easier to manage their appointments, and will have more opportunity to feed back on their experiences. But let's have a look at the three shifts that the plan talks about. Of those three shifts, the shift that perhaps comes through most clearly in this plan is the shift from analog to digital. Technology is really expected to change the way people access and interact with services. The fact that digital will take over many administrative tasks that are going to free up staff time, and even prevent ill health happening by allowing for sort of predictive and personalised care based on genetic sequencing. So within the digital side of the plan, key proposals include a transformation of the NHS app to include a wide variety of new functions designed to help people manage their health and care with increased health information and signposting to services. They're talking about revisiting the health store to enable patients to have access to a variety of health apps, and they'll be paid for by the NHS. There's a recommitment to rolling out the single patient record, which has been in place for many years, but we've not ever quite got there. But they're planning to introduce legislation to give patients the right to access their record and place a duty on providers to record information into it and allow data to be used for research and service improvement. And lastly, and I guess not surprisingly, there's a rollout of technological tools for staff, including artificial intelligence and scribes, which they're citing as a key feature of the future care model, and particularly framing that side of things in terms of how we're going to increase productivity. So if that's the sort of first big emphasis in the plan, then coming a close second is the shift from hospital to community, with new neighbourhood health service sitting at the centre of the new offer. So, forget national health being, the NHS being national health, it's now moving to neighbourhood health service as a new offer to the public about how they can access care closer to home. And within that, key proposals include shifting the pattern of health spending, which I think is going to be fascinating for us to maybe consider further, with the share of expenditure on hospital care falling and proportionately greater investment in out-of-hospital care. They're talking about establishing a neighbourhood health centre in every community, starting in places where the healthy life expectancy is at its lowest, and the government is considering the use of public and private partnerships to support these centres, because of course one of the things that we're really constrained on is the availability of capital. And they're also talking about introducing 2 new GP contracts. And remember, for our primary care system, the providers of primary care are contracted separately from other healthcare providers. So they have a separate contract. So they're talking about bringing 2 new contracts in, with the rollout beginning in 2026. One of them is to create the single neighbourhood provider. So if you think about these neighbourhood health centres that they're going to have, they're asking GP providers to really focus on that geography, but they're also creating a second contract, which would be multi-neighbourhood providers, which basically means that if there's an economy of scale or a specialism that can be delivered out of hospital, then that will be done by a provider who will care across a number of different neighbourhoods. So that'll be interesting to see how that's going to start to play through. But the plan's vision for neighbourhood health will be supported. You know, the government are really clear that they're going to support it by a shift in the overall proportion of expenditure. And whilst it's welcome, I think theoretically a lot of people are thinking that's a good thing. This isn't a new idea. The radical change, I think, will be how the vision is delivered in the right way. So this vision for shift between hospital spend into community has been there for a while. Nobody's really truly making it happen. And part of the reason I think we think as acute providers is that a lot of the focus of governance and regulatory monitoring is still based around the hospital systems, and partly because it's much more difficult, as I'm sure you find, to really understand what happens in community care. But that's got to shift, I think. So I think this whole thing about neighbourhood care, and maybe we can explore that further in our discussions. You know, it's not just true neighbourhood care isn't just about the location of services, but actually really about getting to the heart of improving population health. And I was really interested to see a colleague of mine who's based over in New Zealand wrote an article on LinkedIn recently. And he said, if the plan is truly bringing health closer to the community, it should start by already looking at the assets that are already on the ground, hospitals, clinics, and sort of GP surgeries, but reorientating them around the needs that they were built to serve. He said the transfer that matters isn't geographical, it's conceptual. It's about moving away from abstract strategies and towards a grounded human connection between the service and the citizen. And that really struck a chord for me, because I think we've probably lost some of that, particularly through the challenges that we experience at the moment. So I think what we're seeing is effective neighbourhood services being co-designed with communities and supported by trusted relationships that extend far beyond clinical care. And so increasingly we're seeing the recognition, I think, of voluntary and community and social enterprise sector, not just as service providers, as presented in this plan, but also as strategic partners, as advocates, and as bridges to the community. All too often, I think the model describes, reads as an offer to individuals focused on delivering services to patients rather than building services with and for communities. And again, I think that might be a useful thing for us to pick up in our discussion. There are, I think, some important considerations to be made about how we go about the shift from hospitals to community. So if an NHS hospital provider assumes responsibility for neighbourhood health services, this will need to be done in partnership with local organisations and focus on communities and improving the health of the local population, rather than just reducing the pressures of existing services. So I think, you know, the danger is that the hospital providers just are in the mindset of, you know, how do they do this shift in order to relieve the pressure on the hospital? And that might be a byproduct of it, but it's got to be about how do they really create this neighbourhood care in order, you know, to really make an impact. Because I think there's a risk that by simply relocating hospital-based biomedical models of care into community settings, that you don't then get the real benefits of what could be delivered through community services and community health. And so the neighbourhood health service must be fundamentally different and more than just a local and smaller outpost of an NHS hospital. So it's the shift from treatment to prevention, the last of the three shifts, if you like, that feels where the government has not been as bold or as radical as we'd have hoped. We know that England is an international outlier with a stagnating life expectancy and increasing numbers of years spent in poor health for our population. And although within the plan there were some welcome measures outlined to reduce obesity rates and attempts to reduce alcohol harms, it still feels quite weak in terms of content. And the package as a whole doesn't meet the scale of the health challenges that I think we face as a country. And that's disappointing, but perhaps not as unexpected as the shift from treatment to prevention is a much longer transition that even a couple of government terms will outlast. So nobody seems to have worked out right, I think, how to manage this transition from sort of treatment to prevention while still trying to deal with the really pressurized services that we have today. So that's a sort of overview about what's in there. But the thing that sort of struck me when I was preparing for this is, what does that really mean for Australian healthcare? I think it was sort of prompted by the topic that you raised in your feedback, which is, does this learning sort of translate across sectors, or is it just specific to? So I've tried to really think about, does the 10-year plan really just affect this small island a long, long way away from you, or does it have any particular relevance to the healthcare sector for you? So I think ultimately, we can't doubt that the 10-year plan provides valuable insights to tackling modern healthcare challenges wherever you are in the world. But we probably need to acknowledge that the structural differences between our two countries in terms of healthcare systems and our funding models and delivery structures, we need to take those into account whilst thinking about its direct applicability to Australia. But that said, I think there's certain strategies and principles that could really inform policy discussions or adaptations within Australia's unique context. So both countries, I think, can benefit from shared learning on areas like technology adoption, workforce planning, and how we really think about our staff, and from preventative health initiatives. So I've just listed on the screen there some ideas that I had where I think there's a real relevance, and I can see applicability between what's said in the NHS plan compared to what's happening in your part of the world. So particularly around integrated and place-based care. I think both countries can benefit from better integration between different levels of care, whether that's primary, secondary and tertiary, to really improve patient outcomes. And in the NHS, we see the focus of development of that place-based model in the way that I've talked about, that really needs to consider population needs and resources. But in Australia, I understand that you have primary health networks, these PHNs, that aim for similar integration, emphasising that localised healthcare delivery. So perhaps we could explore some of that. This emphasis on prevention that I just talked about, I think we can see that there is a really heavy focus on the vision for a focus on prevention, really investing in preventative measures and in public health campaigns to reduce chronic disease burden. But also within the plan, there's a heavy emphasis on health inequalities with aspirations to address the social determinants of health, to minimise the disparities between people based on geography or race or wealth. And we also see that prioritised within the Australian healthcare sessions with initiatives such as the Preventative Health and Physical Activity Strategy, which is aimed again at reducing the prevalence of chronic diseases such as heart disease, diabetes and obesity. And And I loved it, reading up on it. You know, some of the initiatives which I know you'll be familiar with, which is like get on your bike. And I'm thinking, only in Australia will they call. You know, we tend to call it something really fundamental. You know, something really formal. And in Australia, you just call it get on your bike. So I thought that was great, particularly in terms of encouraging, children to build lifelong habits. But I also understand in Victoria, there's initiatives to promote healthy eating habits, such as school-based programs, such as fruit and vegetables in school program, really encouraging that sort of daily consumption, and campaigns like Vic Health, which is focusing on reducing obesity by advocating for healthier food choices. So I think a lot of synergies between what we're trying to do on prevention, but maybe understanding how that practically gets the focus it needs if we're really going to build better the population's health much better and stronger over the coming decades. And we shouldn't forget mental health. So you've got initiatives such as BU to improve the mental health support in schools by really training teachers and staff to identify early on mental health issues. And I'd like to understand a bit more about that, because I think that sounds really powerful. When I address, I've just mentioned health inequalities, but I think, again, both our countries recognise that health outcomes are significantly influenced by social determinants such as income, education, employment, housing, and access to services. And we both have initiatives that are often aimed at improving living conditions and providing greater support in disadvantaged communities and targeting vulnerable groups, including low-income families and Indigenous populations. In the case, I think of Australia, the First Nations people in Australia, but ethnic minorities, the elderly, and those with disabilities. So we've both got a real focus on that. But are they really turning, the cogs quick enough? Both our areas invest in data collection and analysis to identify the health disparities and measure the impact of the interventions. And similarly, both our countries take an evidence-based approach in order to guide policy development and programme implementation that really aimed at tackling these health inequalities more effectively. So whilst the NHS long-term plan to tackle health inequalities includes specific commitments, Australia has got the got my teeth in properly today, closing the gap framework so that we can, I think, really, this is a particular area that I think we can benefit from learning from each other, not least because it's probably the most far-reaching and most difficult of the aspirations within the plan to achieve. We talked in previous sessions about workforce, our staff, about their development, about making sure that we're not burning staff out, because internationally we know that providers are struggling to retain and recruit sufficient staff to keep pace with demand for healthcare services. And therefore, the strategies to address workforce shortages and improve working conditions really apply and are relevant to both across both of our contexts. Some key aspects from the NHS 10-year plan that might have applicability to your side of the world include workforce planning and development. The plan emphasises comprehensive workforce planning to ensure the right mix of skills, roles and numbers across different sectors and regions. It includes initiatives for more strategic training development programmes to really build capacity in critical areas such as primary care, mental health and community services. And the plan, which I think has been quite controversial over here, really encourages the expansion of non-medical staff through task shifting and role substitution to allow nurses and pharmacists and other healthcare professionals, so that the sort of controversy has been around introducing physicians associates and whether that should be a permanent feature in our workforce. So good to hear what you're doing over in Australia around that. But it's really thinking about, are there tasks and roles and activities that have previously been undertaken by doctors that can be undertaken by others, and to free up their time to focus on the things that only doctors can do. There's a strong focus on strengthening primary care as the cornerstone of health systems. And the plan talks about empowering general practitioners or GPs and community-based teams in order to become more proactive and preventative in terms of care. And again, I think that has a huge relevance for Australia in addressing workforce distribution challenges and reducing pressures on secondary and tertiary care facilities. And in one of our last sessions, I talked about attracting and retaining talent. And the NHS is exploring more flexible working arrangements, including part-time roles and job sharing options. Offering flexibility can quite often, help be some of the solution to addressing those workforce shortages by accommodating different life stages and personal commitments of healthcare workers. And we've also acknowledged the impact of burnout and stress amongst healthcare workers. And in this plan, the NHS is prioritising mental health support initiatives and providing robust support systems aimed at enhancing job in satisfaction and therefore improving retention rates. And I think that has a relevance wherever in the world you are. And then lastly on this, digital and innovation, I think it goes without saying that there's always transferable approaches between us in relation to digital and information and innovation. And the plan emphasises a comprehensive digital transformation across the NHS with goals to integrate advanced technologies into all aspects of care delivery. There's a strong focus this time round on digitalising primary care services. My view is that they're probably better off in relation to other parts of the NHS, but there is a particular emphasis on enabling GPs to access up-to-date patient records. So maybe it's more about how do GPs gain access to hospital records that's going to be more important, and also using decision support tools. The NHS plan highlights the expansion of telemedicine services and remote monitoring technologies, and that's particularly relevant when we come and talk about virtual wards, but also the use of AI and advanced data analytics to improve diagnostic accuracy and to personalise treatment plans and to predict patient outcomes. So, and not surprisingly, and particularly again, what we're seeing across the world is the NHS plan includes robust cyber security measures as a core component of its digital strategy. And like I say, who isn't focused on strengthening their data protection practices given the threats we face globally in this respect? So I think for me, having sat and really considered it, I think there probably is, quite a lot that's of relevance within what the NHS plan is saying and the sorts of key things that you're trying to tackle over in Australia. So with that all in mind, in this final part of the presentation, I wanted to also almost move away from the sort of strategic and the rhetoric and into some of the practical aspects of implementation and touch on one of the topics that you requested around finding out a bit more about what was happening in England around virtual wards and or whether you call it virtual wards, hospital at home. I know it's sort of referred to interchangeably here. And of course, this fits really nicely with the hospital to community shift that I've highlighted within the 10-year plan. So as you'll know, virtual wards provide hospital level care to patients in their own homes. There are many different models of virtual wards. So some of them can just cover specific conditions such as frailty or acute respiratory infections or heart failure, whilst others have a very much broader range of patients. But in April 2022, NHS England launched its national virtual ward programme with the long-term aim of ensuring that every 100,000 people in England had access to 40 or 50 virtual ward beds. So for that size of population, every 100,000 should have 40 to 50 virtual ward beds. And so far, every ICB or Integrated Care Board in England has introduced virtual wards. So they are geographically spread now across the country. And aims of the programme include improving patient choice and experience, avoiding the risks associated with inpatient stays, of which we know there are many, and also improving hospital flow by reducing lengths of stay and freeing up beds, because it is one of the main challenges I think that hospital providers are experiencing at the moment is longer lengths of stay, because people come in, they deteriorate as soon. We know, people spend a long time in hospital, they're much more likely to sort of see a decline in their health, and that means then that they spend longer in hospital. So by trying to keep people well in their own homes, hopefully we can have an impact in terms of that. Now, NHS England has created a clear definition for virtual wards. They are short stay, i.e. anything up to 14 days. They're acute only services for people who would otherwise be in hospital. So we're not talking about dealing with people in the community differently. We're talking about preventing people from going into hospital, or indeed stepping back down from hospital. And their definition says that patients should have access to the same services they would in hospital, so including urgent diagnostics, blood tests, intravenous therapy, and 24-hour management from a multidisciplinary team, and face-to-face meeting with specialists. So I've already said there's lots of different kinds of wards, but approximately half of virtual wards in England are either for frailty or for acute respiratory infection pathways. And up to 50% of people who are clinically suitable for clinical wards could be treated on either frailty or acute respiratory infection virtual wards. So they're the biggest virtual bed types that we have. But I thought, there's been a lot of debate in England about whether virtual wards will really make a difference in terms of the healthcare sort of setup. And so I thought, well, rather than just talking about what's intended by them, let's see if we can find any case studies. And in actual fact, if you looked on NHS England's website, there's quite a lot of material that's available if you wanted to look into virtual wards. And I don't know how prevalent they are over in Victoria, and perhaps we can talk about that. But the two case studies I've picked up on, the first is an evaluation of the southeast of England, their regional evaluation of their virtual wards. And I think that this report is one of the largest of its type globally, because it analysed over 22,000 virtual ward admissions across 29 southeast virtual wards, which accounted for roughly half of the southeast's overall virtual capacity. So the South East established its wards with the objective of managing patients remotely, particularly those who suffered from chronic conditions such as heart failure and COPD. And the virtual wards leveraged digital technologies such as remote monitoring devices and telehealth platforms to provide continuous patient care at home. And the evaluation demonstrated significant improvements in clinical outcomes for patients enrolled in the virtual ward programme. Notably, there was a marked reduction in hospital admissions and the length of stay, and patients experienced better management of their conditions due to proactive monitoring. And just as an aside, my mum came home from hospital a couple of years ago having suffered heart failure. And I think, the difference that we'd experienced if she'd have been in a virtual ward was that at that point, people were ringing every day for me to take oxygen sats and to give her blood pressure. Whereas if she'd have been wearing a remote device, they could have just remotely accessed that information without that phone call, without taking a person at the other end of the phone to do that, and also set the computer to highlight if she came outside of any preset parameters. And I think that would have made a big difference to not only mum's care and my need to do that, but also I think she'd have got, quicker access to specialist advice if she'd have been outside of the parameters that they were monitoring. So I think there is something about not only does this idea of the virtual ward change the location of the patients, but I think it changes the process that the patients have through their care, which has got to be a better thing. I think the important thing was some of the stats, So within this analysis, they looked from the wards that they analysed alone, the virtual ward admissions were correlated with over 9,000 avoided non-elective admissions a year. So 9,000 admissions were avoided by use of virtual wards. And of the 18 pathways that the report evaluates, there was an overall total annualised net benefit of £10.4 million. So, we're not talking small amounts here around the margins, and that's why this was such an important evaluation, because there was lots of questions about is the cost same out in the community as it is within a hospital bed. But this suggests that overall admission avoidance virtual wards do provide cost-effective solutions to care when they're compared with traditional inpatient stays. Some of the practical things that came out of the evaluation from the clinicians, they said they felt that the virtual ward delivery really championed patient-centred care and achieved success with the support of strong clinical leadership that advocated for the experience of patients and clinicians at a system level. So they were saying that that was a really important component of this. You couldn't just run it alongside your hospital system. You really had to have leadership teams that were specifically focused on developing the virtual ward capacity, and the capability of virtual ward services to effectively meet acute patient needs in the community is a common challenge. They recognise that in the evaluation, because services can lack the equipment, the skills, or the clinical governance that's sometimes required to deliver the required interventions, such as intravenous fluids. So there was a lot of instances I think they picked up on where they said, the ideal would be that the patient was treated in the community, but until they ironed out some of those things, what they found is there was still a requirement for a hospital admission because they didn't have some of the right things in place. And so the evaluation identified a clear set of enablers, including having sufficient funding, experienced staff, collaborative working, and strong clinical leadership, and some of the barriers such as inadequate resourcing, fragmented leadership, and misaligned digital strategies that were needed to be in place to really ensure that you had virtual ward working. Now, I think one of the really interesting things for me in this evaluation is that it highlighted that Black and minority ethnic people were consistently underrepresented in the virtual ward patient cohorts. But it also acknowledged that there were significant gaps in the ethnicity data that might have had an impact. But there has to be a question about, do virtual wards, are we just extending the health inequalities through the implementation of them? And is there more that's needed to ensure that BME patients are appropriately represented in terms of the cohort? So case study 2 comes from Hull and East Riding, which is up in the northeast of the country. The teams worked as part of the City Health Care Partnership CIC, Community Interest Company, and they described how their virtual ward worked. They had a health or social care professional, such as a paramedic, a GP, or a community nurse. They will call in to the frailty team to refer the potential patients. They will then assess them over telephone or video to identify any clinical problems or issues and agree if they're suitable for the virtual ward. And then having full access to the patient records and sharing advance care plans across primary care and secondary care is vital. They said that was really important. And they found that using video with people and their relatives for advanced care planning is valued and effective. They found the need to access urgent diagnostics, including bloods, ECGs, and bladder scans. And they were just at the point in the case study of piloting blood point of care testing and digital stethoscopes. They're able to prescribe electronically, which helps them cover a large geographical area. And by working with infectious disease colleagues, they're also providing patients with intravenous antibiotics. So just some examples there, I think, of what's happening in terms of virtual wards. And I think importantly, those findings from the Southeast, that actually there is some real financial benefits as well as patient experience and outcome benefits that are attributed to that. And so lastly, just to summarise on the presentation, We've had the 10-year plan that's been published. It's got 3 main shifts: hospital community, treatment to prevention, analog to digital. And I've given you some practical examples on the hospital to community about how that's being implemented. But the key question is, will it be sufficient to address the demands of an ageing population with multiple comorbidities? And I think the answer to that is, it will really depend on how brave and bold we're prepared to be in implementation, given all of the sort of barriers, if you like, that are placed on us by the day-to-day management of a really pressurized environment. And so that sort of leaves me, I guess, into our question and answers and our point where we can bring up the discussion. So I don't know if we have any questions already, Craig, but I'll hand back over to you to pick up on that side of things.
Good stuff. Thank you, Suzanne. Some incredible content there. You covered a lot of ground in that period of time, so thank you for that. But yeah, we've got 10 minutes left, so let's jump into any questions. Jimmy.
Yeah, thanks, Craig. Thanks, Suzanne. It was very interesting. I'm just wondering if you were to apply that here in our setting here. Everything revolves around funding, even though our ultimate goal is patient. So treatment to prevention, how would they fund that in UK for those kind of activities? Thank you. Yeah.
Well, it's fascinating, Jimmy, because I think that you've just hit on one of the key aspects of this, which really needs some careful thinking through. So, and there's a real sort of lack of alignment at the moment, because the 10-year plan. So we had a system that was introduced probably 10, 12 years ago, where it was called payments by results. And essentially we were paid in the hospital setting for every patient contact that we had, whether that was an inpatient stay or an outpatient or a diagnostic. And then over time, and the intent of that was to align with policy, which was really focused at that point by the Labour government to try and reduce waiting times. So they wanted to encourage organisations to actually undertake more activity, and hence payments by results got implemented. And then over time, what the healthcare payers were finding is that because that was organisations have been recompensed at full cost, that actually that was putting more cost into the health system overall and was leading to overspends. So the healthcare commissioners started to put arrangements in place where they either blocked out the level of activity that was purchased for a level of resources, and organisations started doing extra work at marginal cost, or they did away with it altogether and did a block contract. Now, interestingly, the plan starts to talk about unpicking those block contracts and starting to take away that sort of payment for a population. And yet, I'm involved with a couple of organisations that are commissioning community and mental health services for different parts of England. And they're talking about having a contract payment in full for a population that then is dependent on outcomes. So it moves away from being dependent on inputs and starts to focus not on outputs, but on outcomes. And that's incredibly difficult, but that could fly in the face of the sort of block arrangements that the government in this plan wants to try and do away with. And so I think the straight answer is that is very much still needs to be developed. And at the moment, we could be going to opposite ends of the spectrum, depending on which part of the plan or which part of the initiative you're looking at. But I think, the answer's got to be that you start to move to payments for organisations based on outcome. And what we found in the project that's just been completed is that was a 7-year contract with 2 extra years potential. What it allowed the company, and actually it was a private healthcare provider that came in and secured the contract, but what it allowed them to do was to invest more heavily in digital upfront and recover the costs of that later on down the line, because they could allow for the fact that the activity may be slower, while they were doing that transition, but actually would pick up later in time. And the fact that that contract was based on outcomes meant that was the thing that they were focused on, not the numbers of patients that they treated. So I hope that helps, but I don't think we've necessarily got the end answer yet. That's very much still in development.
Yep, that was helpful, Susan. Thank you.
All right, David.
Would you be able to tease that out a little bit more, Suzanne, around the funding on outcomes? You know, that's sort of a key tenet of value-based healthcare. And, you know, when we're talking about where we can invest to get best value, we're talking about where can we invest to get best outcomes. And so it is a sort of a shift from a capitated to an activity-driven to an outcomes-based model. I'm just interested to see how that's being, I guess, discussed and considered at the moment over there.
Yeah. Well, it has been fascinating because, like I say, the commissioning group that I was working with were really clear that for community services, they didn't want it to be based on contacts, because partly because they wanted to move to new models of care. So they wanted to move from, you know, patients having to turn up to a local clinic to digital contact, and all sorts of things. So that was partly what drove them, but partly it was this concept that just seeing people more doesn't necessarily result in a better quality of health result. And so they were really thinking about how they could move to it. Now, one of the interesting parts of the dialogue that I had with them was that although they had that as their overall objective and aim, they still got themselves caught back up into either specifying the service, i.e., you know, if they didn't specify the inputs, which they found difficult not to do, they were definitely specifying outputs as opposed to outcomes and moving them into that. Now, I think that they've still got some way to go, but they started really well. And if it's helpful, I'm really happy to share some examples, you know, what the stuff that I can without compromising their confidentiality. But I'm really happy to circulate to this group some of the specifics on outcomes that they identified, because I think by seeing those, you might find that helpful.
That would be very interesting, I guess, because volumes or contacts, or where we've got our coding practices for activity-based funding, it's easily measurable. Outcomes are going to be clearly defined, difficult to monitor, difficult to measure. It's always been the biggest barrier around sort of this transition to outcome-based healthcare rather than volumes or widgets, however you want to sort of describe it.
I think we're going to see, and you heard me reference patient experience and lived experience, but patient experience more specifically. I think increasingly we're going to see more in terms of patient-reported outcome measures. So, you know, if the patient feels they were on a scale of 6 out of 10 before and they're feeling 8 out of 10 now, does that start to trigger payments? I don't know, but I wouldn't be surprised if that's where we didn't go in the future.
I agree. I think the proms and prims are going to be
a big factor.
A big factor. Yeah.
Yeah. Okay. Can I ask a quick question? Oh, sorry, Simfrey. But my quick question was, how much are virtual wards being used in Victoria? Are they a big factor of your healthcare system as it stands at the moment? Maybe we can come on to that after Simfrey's asked her point.
Yeah, I think let Simfrey ask her point. We can then address that.
Probably better to go to your question, Suzanne, because mine is probably taking away from the current topic that we're discussing.
Okay. Yeah.
I saw Jimmy go off mute. Do you want to go first?
Sorry, thanks, David. So we got a virtual emergency ward, and then followed by that, if the patient is not well enough to send back or refer to the GB, we admit them to a virtual ward, where normally we observe them for half a day or full day, where a physio or a doctor, a consultant will be doing monitoring the patient. So it is working very well. We got very good positive feedback from the patients as well. We are planning to do that elsewhere as well, but the other areas, our virtual is limited to a follow-up contact just to make sure they are okay. For example, from a physical ED, once they are discharged, we just maybe make a call to make sure they are okay at home, so those kind of follow-ups. Yeah, it is working well, to summarize, but we need to grow a lot more because at the moment it's centralized. Northern is providing for the whole of Victoria, but I think it will be good to roll out into other hospitals as well. Thank you.
Yeah, cool. Thanks, Jimmy.
So that's on the ED side. We definitely have programs of hospital in the home across our pediatrics, acute, and I'm looking at Ross because in our rehab program, I think it's rehab, or is it our GEM wards, Ross, or is it both?
It's subacute, so it goes
Subacute
across
general.
GEM and rehab. I was just going to try and get the numbers. We're starting to see really good numbers around length of stay and throughput through that area over about the last 6 months. Yeah, so it looks to be really working and something we can expand. One of the thoughts I actually had on the way through there was, we're sort of activity-based funded, and I don't know how you'd ever do it, but doctors' appointments are limited, or doctors might only be getting to 2 patients a day through this service. I wonder whether they could be activity-based paid and would see improvement in that, or whether there might be sort of a pull to improve those numbers.
So you're saying, Ross, that that's one of the constraints of the virtual ward is getting enough doctor input to.
Yeah, and technology might help that. And probably example, and it's a bit or it's personal or known to me. My wife works in a private team at a once a month or whatever, but her boss has this photographic memory and knocks over seeing 80 patients a day and is a brilliant physician. In a private setting, he's rewarded for that. In a public setting, he wouldn't be. He'd be on an hourly rate, and then that productivity drops off. But I don't know how you'd ever work it all.
Yeah.
Then the trade-off, Ross, though, like Suzanne was talking about, outcomes versus volume. So you might be able to churn through 80, but the outcome for all your patients longitudinally is worse. So you're actually putting more pressure on the sector. So it's a really interesting balance of how do you incentivize the right behaviours to get best value for patients, community, and your health services. So it's a fascinating sort of front point that our health services are in at the moment.
And the other one Jimmy talked of, I reckon, was allied health input early on in an emergency or early on after operations, and looking at length of stay after that and those sorts of things. There's some really good numbers out of that.
And also, Ross, don't forget, being tertiary hospital, training also slows down the outputs.
Yeah, could we have non-training wards or non-training, which I think I've suggested that to Al Saunder, and I didn't get very well with that. Who's the head of surgery here?
Okay.
No, the tertiary part is an important part of our service delivery.
Brilliant.
Good. Excellent, thank you. Simfrey, we'll wrap up with yourself. But what was your question?
Thank you for that. Just to comment as well on virtual wards, they don't work in areas where I am currently. Basically because one of the main reasons is obviously technology, because our patients are in very remote areas, most of them probably not very, the level of education is not that high as well, so it's a bit of a challenge there. It's been tried, it just hasn't worked out. We've actually had to close that. And I don't know whether, I know you did mention, Suzanne, something to do with whether that works with minority groups, whether that's because of education, or I'm not sure what the reason for that would be in the UK. But I was interested to find out from the UK. You mentioned about closing the gap, which is a real big issue, not in the metros as much as it's in the remote and rural areas where we are, where the gap is very apparent in terms of levels of education, provision of primary health care, Yeah, I was just wondering with that, how is the UK addressing that gap?
Yeah, so I mean, and that might be, I mean, I think it's a great question. And it might be I can do a bit of research further on that one, and we can add that to the topics list, Simfrey, because I think that whole bit is you know, is a session in itself, I guess. But if you'd find that useful, we could certainly look at addressing health inequalities. There's a couple of things that I think have come up today. One is the health inequalities, but I also think this idea of how you get into an outcomes-based framework and payment methods or payment mechanisms that that match that and support it might be something useful for us to pick up.
Yeah, and I guess, look, how do we deliver the services in a different manner that will be more acceptable to our minority groups or
Yes.
to our First Nations? Is there
Yeah.
something that we have to do different to what we've been trying?
Sure.
When we've been doing
Yeah.
the same thing for a long time, do we approach
Yes.
that differently?
Yeah, that's a great question. Great question. Yeah, okay. I'll bear that in mind for some future topics. Craig, I'm sure you'll want to wrap up now because I know we're slightly over
Yes.
time, but could I just take a moment to check whether the proposal we had for the next session around utilising what you've already got, as my digital colleague at work tells me, the term is shopping from your own stack. He says it much cooler than I do, but would you find that a useful one to have a look at in terms of how that's really driving productivity in England?
Yep. I think
Yep.
we would.
Okay.
Like, it's
Yep.
what we're being asked to do from a state level. You've got what you've got.
Okay.
How can you do more
Yep.
with it?
Okay. So this is about, you know, because what he'll talk about is Microsoft, you know, people are using Word and Excel and PowerPoint, but there's so much more you could be doing that might solve and help you standardize some of your processes and take out human intervention. So if I can give you some good examples around that, would that go down? Would that be useful? Perfect. Okay. In which case I will be thinking about that for our next session.
Good stuff. Thank you, Suzanne. Thank you, everyone, for coming on today. We've overrun slightly there, but some really good questions to talk about, and I've certainly enjoyed it, and I'll be taking away a lot from this as well. Just a reminder, obviously, Atlas Partners putting through this event. The next one will be happening in October. So 2 months' time, and yeah, I'll have a chat with Suzanne in terms of what that next session will cover, as well as everyone that's attended tonight. But no, thank you for your time. Thanks for logging on, and yeah, have a great evening.
Thank
Good
you.
to see you all.
Appreciate it.
Take care. Bye.
Thank you.